Are we going to start the recording? Okay. Tanay, are you just faking me out there? Or are we good? Okay.
Recording.
Jason is a clinical professor of pharmacy. He's at University of Michigan School of Pharmacy. And Jason is a leading clinical researcher in the world of antibiotic stewardship and antibiotic resistance. Jason also is not just a pencil neck geek researcher. He is that, but he also has many years in the field, boots on the ground, in some very nasty parts of Detroit, where he really managed major outbreaks of very resistant organisms. Worked a lot with private physicians as well as university-based, and really excited to hear him talk to us about Pseudomonas. So, Jason, the stage is yours.
The virtual floor is mine. Thank you so much, and I appreciate always the kind words, Keith. He overstates my role, but I appreciate that. That's his job, makes him look good too. But again, I thank you for inviting me, and for those of you that came out today virtually for this presentation, just because I know that we're all just crushed as ID clinicians right now. And it's always nice to talk about bacteria instead of viruses right now. So when Keith asked me to come here and give a presentation, you know, I was trying to think, my specialty is always in gram-negative resistance. It's definitely my interest area. It's definitely what I find most challenging as a clinician. And when trying to hone in on, you know, this is an ID audience, this is an expert audience, I really wanted to focus on Pseudomonas, and the reason was multifold. First off, you know, it's interesting the world we live in today, because, you know, when I was in pharmacy school, and probably when a lot of you were in medical school, you know, this was the organism people talked about, right? It was Pseudomonas is the nasty organism. It's associated with drug resistance. Resistance develops on therapy. It's virulent. Outcomes are awful. And, you know, that's kind of how I went into practice. And then over the next 10 to 15 years in the gram-negative space, it kind of got upstaged. First was Acinitobacter came on as a problematic pathogen, particularly in certain institutions, something that Keith and I dealt with a lot when we were in Detroit. And then CRE, right? And so, you know, everyone forgets about Pseudomonas, and Pseudomonas has just been there in the background the whole time, you know. Nothing went away. If you look at impact from antimicrobial resistance, and again, just using carbapenem resistant infections, for example, this still causes more than Acinitobacter and Enterobacterales combined. And so I think it's always important to come back to that and give this organism its due. The second thing is that, you know, with the rise in CRE, with the rise in carbapenem resistant Acinitobacter, our mechanistic thought process has gone largely to beta-lactamases, right? When we think of CRE, when we think of Acinitobacter, we think of carbapenemases. And once that's present, you know, you pretty much lose all beta-lactam options, except maybe some novel agents in certain scenarios. And with Pseudomonas, it's much more complicated. It's a multifactorial mechanism of resistance. Really understanding and appreciating that is how we take care of our patients, know what our good therapeutic options are. And what we're taught, at least, is that, you know, resistance to one beta-lactam doesn't necessarily rule out another, although we're gonna challenge that a little bit today. And so again, it's important to come back and hash these things. But then the third part is that as we've had this renaissance in new drugs for the management of CRE in particular, a lot of them have pseudomonal activity. We have 5 new agents that have come out over the last 7 years, and really understanding the mechanisms of resistance helps you understand if these agents bring anything to the table. We're going to focus a lot on that today, because again, a lot of these agents are beta-lactamase inhibitor based. And so you need to know the role of beta-lactamases in resistance to the parent drug to really get into that. And so the objectives are listed here. Again, I won't read this slide to you, but really the talk today will come in 2 buckets. The first part is the setting the stage part of the presentation. I want you to understand the major mechanisms of beta-lactam resistance, and again, focusing more on the traditional agents like cefepime, piptasa, and the carbapenems, the mechanisms and how they impact different antibiotics. Again, that's going to be critically important to the second part of the talk, which is going to be, we have a bunch of new drugs. Some are available, some aren't available. Do they have options, or are they options for Pseudomonas? Which one should I be thinking about and why that is? And so that's kind of the two buckets this presentation comes into. And so when you talk about Pseudomonas, again, one reason I love talking about this organism is just because it's just so impressive how robust and broad ranging the defense mechanisms are. And I think that one thing to always understand and appreciate as a starting point for Pseudomonas is that there's a lot of intrinsic resistance that's also present. Even in the best case scenario, right, we're talking about a half a dozen to 10 drugs that are potential therapeutic options for this organism. And so to understand everything we're going to get to, we do have to start out with talking about kind of those natural innate defenses. And first and foremost is the impermeability. Again, thinking of a gram-negative organism, what makes a gram-negative different? It's that outer membrane layer, that lipopolysaccharide layer. And again, all gram-negatives have this, but one thing that's notable is that the impermeability factor is up significantly higher for Pseudomonas aeruginosa as compared to the Enterobacterales. And so, for example, the outer membrane is about 1/12 as permeable of that of E. coli. So again, just as a starting point, you need organisms to get past that, or you need drugs to get past that outer membrane, and you're starting off with things that can't get through as well. Even those that do, it's kind of a slow pour-in for entry of beta-lactams. We don't talk a lot about OPRF, but OPRF is really the main beta-lactam mechanism for getting past that outer membrane, but diffusion through there is actually quite slow. And so because of that, best case scenario, you're talking about getting lower concentrations of any drug that might be active that's going to cause elevated MICs and full-blown resistance to some things. In addition, from a permeability standpoint, one thing that we always have to remember with Pseudomonas, this is why carbapenems can have a little bit different spectrum of activity for Pseudomonas, is that the carbapenems do have their own pathway for uptake. It's OPRD. That's a pour-in that's specific to the carbapenems, and that becomes important in a little bit when we talk about carbapenem resistance mechanisms. So that's one thing. The second thing is an inducible AMP-C-like beta-lactamase. And again, AMP-C-like beta-lactamases are in many organisms, but Pseudomonas, again, the ones in Pseudomonas are a little bit different. You'll actually hear them referred to as PDCs, or pseudomonal-derived cephalosporinases, but again, ultimately the same thing. These are AMP-C-like enzymes. There are hundreds of different variants of these, which can differ a little bit in their hydrolytic properties. And so you can see different beta-lactams be affected in different ways. But I think things to keep in mind is twofold. One, it is inducible. So some of the intrinsic resistance that we see for drugs like ampicillin, cefoxitin, much like if we were talking about an Enterobacter species, they kind of induce their own death in that situation. So that's why those drugs aren't anti-pseudomonals. Additionally, there is a basal level of AMP-C-like beta-lactamase that's present. That's why things like ceftriaxone aren't really active for the management of Pseudomonas aeruginosa. So again, know that there's this basal inducible beta-lactamase. And then the other big one, and again, this can affect a wide range of compounds, this is efflux. So always remember, efflux is pumping drug out of the cell once it gets in. There are a number of different efflux pumps that are problematic in Pseudomonas aeruginosa, but the big one for drug resistance is MEX-AB. And we're going to talk more about that in some upcoming slides, but know that there is a basal level of this as well, meaning there's a constitutive background level that's always present. And this impacts different drugs to different degrees. For example, this is the reason that some drugs aren't anti-pseudomonals. Tetracycline and macrolides do get into the cell, but then they just get pumped back out. So they're not agents that can be used for the treatment of Pseudomonas. Additionally, this is why even our quote unquote pan-susceptible Pseudomonads tend to have higher base MICs, because some beta-lactams, notably drugs like piperacillin and aztreonam, are heavily impacted even by the basal levels. And that's why you won't see a Pseudomonas with a piptasal MIC that's better than like 2 or 4, because again, there's going to be some basal level of this that's going on, and it's going to impact different drugs to different degrees. So again, that's our starting point for resistance. Where this gets really bad really fast is when these chromosomal mechanisms of resistance get upregulated. So all of these things, and we're going to talk about each of these individually, but all of these things are regulated by repressor genes. And so what can happen is something that there can be mutations that occur that will cause hyperproduction or upregulation of certain things or downregulation. So again, the things that control expression can be mutated in a form that stops that repression or stops that control. And so if you remember anything from this talk about mechanisms of beta-lactam resistance in Pseudomonas, this is really the key one, guys, as a clinician. This will help you try to figure out what's going on in a given isolate that you might see, but also we're going to come back to this when we talk about the novel agents, because remember what I said before, a lot of the novel agents are BLI based, beta-lactamase inhibitor based. And so if the mechanism of resistance isn't a beta-lactamase, you're not going to see a lot of help in that situation. So the three mechanisms of resistance are listed there. The first one is AMP-C hyperproduction, right? We already talked about basal levels of AMP-C or PDC-based expression. But what can happen is you can have hyperproducing strains. And as you can see, when you see AMP-C hyperproduction, this often leads to high-level resistance to these drugs. Again, it depends on how much enzyme is being produced, but generally, you're looking at MIC rises to those drugs that are affected about 8 to 64-fold. So pretty significant development of resistance. Again, I think it's important to look at our traditional anti-pseudomonal beta-lactams and how they're impacted. If you have a ceftazidime or piptazo-resistant isolate, this is usually the mechanism. Other things that I think are worth noting, one, note that cefepime is a little less impacted than the other agents, than things like piptazo and ceftazidime. A lot of that is due to the chemical structure of cefepime. It's zwitterionic, it gets across the membrane more. But the thing that I always like to highlight is I think this is really overblown, the degree to which this exists. You're usually talking about 1 to 2 dilution decrease in MICs, and it's often still relatively high. But no, there can be some discordance there. So if you have an isolate, right, if you're taking care of a patient and the ceftazidime MIC is 16 and cefepime is 4, one, that could be real, and two, this is most likely your mechanism in that situation. The other thing I want to highlight here is how AMP-C impacts the carbapenems. This becomes really critical, guys, when we talk about the role of new drugs down the road. Imipenem is actually, again, same as with Enterobacter, it's actually a pretty strong inducer of AMP-C. And in addition to that, while it's not completely labile to hydrolysis, it does get hydrolyzed some. You won't really see pseudomonads with Imipenem MICs less than 0.25 because you're going to see this induction of beta-lactamase and then some hydrolysis. The key thing that I will note is that it's not enough to cause resistance on its own, but it's why you'll see isolates are always like 0.25 to 1 when they are susceptible. Conversely, Meropenem is not impacted by this mechanism. At best, the PDCs usually only cause about a 1 dilution increase in Meropenem MIC. Again, we're going to come back to that later. Second column, MEX-AB upregulation. So remember, we talked about this already being there in some basal form, but when this gets upregulated, you can see rises in MICs about 4 to 8-fold. And as you can see, everything that is not Imipenem is impacted by this. And so when you see significant upregulation, you're going to see some significant multi-drug resistance in your Pseudomonas isolate. Usually enough to cause resistance, but even in the best case scenario, you have very barely activity. So again, MIC is right at the break point. Again, please note again the Imipenem Meropenem discordance here, because again, if you've seen isolates where Imipenem is active and Mero is not, or vice versa, you're starting to see why that might be the case. And then the last column is actually specific to carbapenems. Remember, we said OPRD was the porin channel that was specific to the carbapenems from a beta-lactam antibiotic standpoint. And as you can see, what will happen is that, again, due to mutations, you'll see down regulation of those porins, less drug gets in. And as you can see there, rarely will this, and I won't say rarely, I say it's kind of about a coin flip of whether or not this will cause resistance on its own, or if it needs a secondary mechanism of resistance. I think the key thing that I want to highlight for you guys here is that although it's often taught that OPRD downregulation pretty much knocks out Imipenem, but might not be enough to do so for Meropenem. That's actually a little bit of an oversimplification. The reason, so it's absolutely true, but the reason it's true is because remember, Imipenem is going to induce some AMP-C beta-lactamase that's going to inactivate that a little bit. And so it's actually the combination of AMP-C and OPRD that leads to that Imipenem resistance that we see. Again, I spend so much time on this here because we're going to come back to this when we talk about the role of novel agents in the management of Pseudomonas infections. And so what we're always taught, right, is that, oh, before we get there, I almost forgot. That's the, I think that last slide is the big one to remember. This is the majority of the mechanisms of resistance that you're going to see in Pseudomonas. However, know that it's not absolute. And I think that's a really important thing for us to keep in mind that, and hold on, I'm trying to get the slide to go back. There we go. Is that even though those are the main ones, there's other stuff involved too. And it's one of the reasons why any phenotype ends up being fair game with Pseudomonas aeruginosa. For example, remember I said that there are other efflux pumps that are chromosomal in nature for Pseudomonas that just tend to just be bit players. But one interesting example is MEXXY. So MEXXY is interesting because when it is expressed or upregulated, it actually only effluxes cefepime. And so if you've ever seen an isolate in your patient that, again, seems backwards because it's cefepime resistant but ceftazidime susceptible, MEXXY is usually what's at play in that situation. Another kind of signal that that's the case is quinolones and aminoglycosides are often resistant as well because they're shot out by the same efflux pump as well. Additionally, even though it's not our main concern when we talk about Pseudomonas aeruginosa, you can have plasmid-mediated beta-lactamases as well. And as you can see here, different ones are going to differ in which beta-lactams they end up taking out. There are penicillinases, which only impact things like piperacillin tazobactam. There are ESBLs, again, different than the ESBLs that we see in Enterobacterales. And then even though carbapenemases are infrequent, particularly in the United States as mechanisms of carbapenem resistance in Pseudomonas, the players that we see tend to be metallos, and they're actually the non-NDM metallos. Vim and Imp are the ones that you'll see. And again, one thing that should jump out at you here is everything that we're talking about, very little of it's on rapid diagnostics. And so that's a really important teaching point, I think, is that we've come to rely on RDTs, particularly in bloodstream infections, to be able to identify key mechanisms of beta-lactam resistance. But everything here is chromosomal, right? And so because everything here is largely chromosomal, it is not going to be detected. So if you see a Pseudomonas in the blood, no resistance determinants detected, it's important to know that you really haven't ruled anything in or out with regards to susceptibility. But again, because these mechanisms seem to hit different drugs to different degrees, what we always tell people, right, is that even in the setting of resistance to one, you could probably use one of the other main agents. And I think that we're gonna come to that in a second here, but just to kind of bring us, just to rehash where we're at so far. Beta-lactam resistance is complex, right? We saw it on those slides. It's often multifactorial and notably not detected by rapid diagnostics. Like I said, even though we're not really focusing on this today, co-resistance with quinolones and aminoglycosides are common. That's because of shared mechanisms such as efflux and or plasmids that have resistance genes to different resistance determinants to these different classes. And like I said, what we always teach people, and again, I used to be responsible for doing this all the time as well, was, you know, it's okay if you have pip-tazo resistance because Mero might still be an option, or vice versa. And what I'd really challenge you guys with on that is that if you really dig deep into that question, it's not really true. It can be, but it's more the exception than it is the rule. So here's some data that we had at the University of Michigan. And so just to orient you, I want you to look at the left side of your screen right now. And so x-axis is piperacillin tazobactam MIC distributions. They're increasing to the right. And then the y-axis is the percent of isolates that are inhibited at those different MIC distributions. And the blue line that's in the middle, that's the susceptibility breakpoint. And so what you'll see, the red line, that's about 4,000 Pseudomonas at the University of Michigan over a 1-year period. And much like the data that I would assume would be present at Rutgers, you're talking about 20-ish% resistance, 25%. So susceptibility is about 75 to 80%. But what I want you to really appreciate are the other two lines that are on that screen. So the yellow line is all of the Meropenem resistant isolates, and the blue line is all of the cefepime resistant isolates. And what you'll actually find is that once you lose one of those two drugs, pip/tazo is only active 15 to 25% of the time. And even look at that MIC distribution, they're all at or near the breakpoint. And that's why understanding those mechanisms of resistance is important, because that should make sense to you. Because again, if efflux and AMP-C is what's leading to pip/tazo resistance, it is going to impact those drugs to some degree as well. It may or may not cause full-blown resistance, although it usually does. But even when it doesn't, you're borderline in your exposures and MIC breakpoints at that situation. And then if you look at the right side of the screen, again, this is just a way that we graphically presented this. It's just saying that the little blue dot in the middle is isolates that were only resistant to Zosyn and no other drugs. And then as you go around clockwise, it's increasing. 1 extra drug, 2 extra drugs, 3 extra drugs. And all I want you to see is look what the biggest chunk is. Red, which means all of those traditional anti-pseudomonal beta-lactams. And so what I want you really to appreciate is that even though we don't talk about it a lot, co-resistance or cross-resistance amongst beta-lactam is actually quite common. And one thing that I always like to kind of look at and touch on is, you know, just think of what we do as stewards sometimes when we're taking care of patients, right? We say, okay, this patient had recent piperacillin tazobactam, or they're failing piperacillin tazobactam. Let's escalate them to meropenem. And meropenem is a good escalation if you're talking about Enterobacterales, but if you're trying to do that to improve your Pseudomonas coverage, it doesn't really do much. Again, I won't focus on the actual numbers here, but all I want you to see is that when, once again, you look at cefepime or pip/tazo resistant isolates, again, because that's what you're escalating to get away to cover for those types of isolates, your susceptibility rates drop down to about 30%. And the most common thing you're going to see when you see meropenem resistance is resistance to every single agent. And so I think it's really important to appreciate it, and that highlights why we need novel therapies. And so what I want to do for the second half of this talk is talk about the novel therapies and talk about where they fit into this story. Because remember, a lot of these, but not all of them, but a lot of these were actually brought to the market because, as we talked about, KPC came onto the scene. So they may or may not be good for Pseudomonas as well. And we're going to talk about that as we move forward. And so to start us off, let's talk about the agents we've had the longest. It's crazy to call these two drugs old timers, but come next month, we will have ceftolozane tazobactam. Let's assume we have it first. I know it's on shortage, but we should have it again soon. But we've had ceftolozane tazobactam for 7 years now. And ceftazobactam came out 2 months after that. And so we've had these drugs actually for quite a while. So the difference for ceftolozane tazobactam, what's new here? Well, it's ceftolozane. So ceftolozane is a broad spectrum cephalosporin. It's an anti-pseudomonal cephalosporin. Tazobactam is the same tazo you know and love from pip/tazo fame. It's a beta-lactamase inhibitor. But always remember that when it comes to beta-lactamase inhibitors and Pseudomonas, tazobactam doesn't really do anything. Because remember those pseudomonal-derived cephalosporinases we talked about, really no inhibitory properties there. Tazobactam in Zerbaxa is actually to improve the Enterobacterales activity. It does a pretty good job about doing that, particularly with ESBLs, but really irrelevant to our conversation today. But the key thing that you need to remember about ceftolozane, this is why we love ceftolozane and we can't wait for it to come back, is remember those 3 main mechanisms of resistance that we talked about a few slides ago. AMP-C hyperproduction, MEX-AB upregulation, OPRD downregulation, relatively stable in the presence of all of those. So you can often see activity even in your extensively drug-resistant Pseudomonads when it's mediated by upregulation of those chromosomal mechanisms. And then there's ceftazidime, avibactam. Again, you know ceftazidime, we talked about it already. The key addition here was avibactam. This was our first DBO, which was our first non-beta-lactam, beta-lactamase inhibitor. It's a potent inhibitor of class A, C, and some class D enzymes. Most notably, as you guys are probably aware, this came to market predominantly as a KPC drug. The other important thing to note about avibactam, it's not part of our talk today, but in the CRE space, this is actually the only available inhibitor that inhibits OXA48. And so it is a niche for this drug, those OXA48 producers. However, those PDCs are class A enzymes class C enzymes. And because of that, avibactam is actually a potent inhibitor of those enzymes as well. So the question that we commonly will get, or that will commonly come out, is, how do these two drugs fare against resistant Pseudomonas? And there are a number of publications that are out there. I picked this one for two reasons. One, it's more recent. It's from 2017 to 2018 when these drugs were on the market already for a little bit. And two, it's throughout the United States. It's not a single center study. It's giving you that broader picture. And so just to orient you to this, your first column is increasing levels of resistance to Pseudomonas, all comers, MDR, XDR, and then resistant to all beta-lactams, all traditional beta-lactams. And then you're looking at susceptibilities and MIC distributions. And what you see here, right, is that from a percent susceptibility, they look pretty similar, right? You see the MIC 50/90s, there seems to be 1 or 2 dilution advantage to ceftolozane tazobactam, but overall you see similar activity. So the question that we get, right, is, are these drugs interchangeable, right? Are they one and the same? And I would argue that they very much are not one and the same. I think ceftolozane tazobactam has some notable advantages. Just so you guys know, little birdie told me that by the end of this month, you might see this bad boy coming back. So get excited. But I do think that this drug has some notable advantages. First off, again, I'm an ID pharmacist, right? PK/PD is a large part of my profession and my career. But there is a potency advantage that comes with ceftolozane tazobactam. You will often find in those XDR isolates, the MIC is around 1 to 2, whereas with Cas-Avi, it's about 4 to 8. But even more so, that's only one piece of the story. I think that second bullet is what's really important. First off, remember, tazobactam is irrelevant to this conversation. All we need to worry about for Pseudomonas is optimizing one drug, the parent drug ceftolozane. And just so you know, there are robust PK/PD data that are available both in healthy volunteers, in floor patients, in ICU patients. And not only do they suggest that PK/PD targets can be met for susceptible isolates, they actually suggest that even low-level resistant isolates, MICs of 8 to 16, you could hit your PK/PD targets. And I'm not even talking about like the bare minimum PD target of time above the MIC of 50%, even some of those more aggressive targets that we think about when we're talking about critically ill patients, like time above the MIC of 100%. And so you actually have a little bit of wiggle room with your exposures, particularly if you extend the infusions of ceftolozane tazobactam. So there's a real PK/PD advantage to this drug. Conversely, I would argue that there's a lot of concerns out there with Cas-Avi with regards to PK/PD. First off, remember, MICs are often at or near the breakpoint. We looked at, again, go back to this slide, even for just MDR isolates, you're talking about an MIC 50 of 2. When you start to get into those isolates where we really want to use the drug, you're talking about MIC 50s of 4 or 8. And guys, that should make sense to you. Because remember, as we talked about before, ceftazidime resistance is driven by 2 things, AMP-C hyperproduction and efflux upregulation. So no matter how good avibactam is at inhibiting AMP-C, it can't kick the drug back into the cell whenever it's being effluxed out, right? So you can only get so far in this situation. And unfortunately, that means that you need to optimize the exposures of both ceftazidime and avibactam. And I would argue that very little work has been done looking at Vaporbactam PKPD. So I just don't feel comfortable that the exposures are right. In addition, when you compare it to other cephalosporins, it doesn't get into the lung quite as well, which might have implications for the treatment of pneumonia, particularly given that those isolates tend to have higher MICs where we're using this. And again, bottom line is that you're restoring these isolates to a ceftazidime MIC of 4 or 8. And I don't know about you guys, but I get a little bit squirrely with ceftaz when that's what the MIC is. I certainly get squirrely with cefepime when the MIC is at 4 or 8. And so again, there's a lot of borderline activity in my opinion. And in the absence of real world data showing it to be efficacious, showing it to be comparatively efficacious, you know, I worry a little bit about that drug, which leads to the other, you know, real benefit, I think, for ceftolozane tazobactam is we actually have data, real world data, treating MDR, XDR Pseudomonas, showing improved outcomes over our historical crappy treatment options. And so this was a retrospective multi-center comparative effectiveness study that we did in 6 sites in Southeast Michigan and Central Ohio. So obviously it wasn't this week, right? Because we would have been gearing up for the Michigan-Ohio State game and no one could have agreed to do the study together. But we did this, it wasn't right on the table, it wasn't right in our face at that point in time. And so what we did is we compared patients who had these XDR Pseudomonads who got CT, and we compared them to patients before CT was available, and they got polymyxin largely based therapy. Again, this were the patient population that you're most interested in, largely pneumonia, largely VAP actually, 2/3 in the ICU, and about half were critically ill in severe sepsis or septic shock. And despite only having 100 patients in each group, we were able to see that clinical cure was 2.5 times more likely if you got ceftolozane tazobactam. There was a non-significant decrease in mortality. We were absolutely underpowered to answer that question. But much like some of those other novel agents in the KPC space, we saw a 12-fold decrease in acute kidney injury as well. And so in addition to all the theoretical advantages with CT, it also has the benefit, we actually have real world comparative data showing it works. And so I think that those are all advantages.
Hello.
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 All right. All right, so that was kind of our first 2 novel drugs. And in 2017, Meropenem Vaporbactam came onto the market. So you know Meropenem, the difference here was Vaporbactam. So Vaporbactam is a unique boronic acid-based beta-lactamase inhibitor. And what I want you to know about Vaporbactam is that it was actually synthetically designed. Literally, they drew this compound on the board, on a whiteboard, and then they synthesized it. They really designed this compound to optimize the interaction and inhibition of KPC. And it does that extremely well. That is not the point of our talk today, but this is absolutely your go-to KPC drug, in my opinion. However, because it's a boronic acid-based inhibitor, it also has inhibitory activity against other class A and class C enzymes, including AMP-C. So the question is does this bring anything to the table for Pseudomonas? And the answer is not really. So why is that? Well, 2 main reasons. First off, remember we talked about Meropenem, we talked that it was subject to issues with porin, had to get in OPRD, and efflux. And Vaporbactam is actually subject to both of those things too. So when there's an issue for one, there's actually an issue for the other one as well. But in addition to that, the more important thing, and this is why we spent so much time on that slide, guys, is that remember, unlike Imipenem, PDCs really have almost no impact on Meropenem, maybe only a dilution or 2 in certain scenarios, but usually it really doesn't impact it in any way, shape, or form. And so if you look at comparative MIC 50 and 90s in Meropenem-resistant Pseudomonads, you'll see no difference between the 2. And again, understanding the mechanism of Meropenem resistance, this should make perfect sense to you. But this comes with a catch, because the thing about Meropenem Vaporbactam is that it can actually confuse you. It can actually mislead you into thinking it's, whoa, this is a great anti-pseudomonal drug. So let's start off with Meropenem. So Meropenem, the susceptibility breakpoint for Pseudomonas aeruginosa is 2. The reason that it is 2 is because the standard dose of Meropenem is 1 gram every 8 hours is a 30-minute infusion. That's what actually drives the susceptibility breakpoint. The thing you need to understand about Meropenem resistance in Pseudomonas, again, because it's often efflux based, is that the majority of resistance is actually low level. You can see that half of Meropenem resistant isolates are susceptible at an MIC breakpoint of 8, right? You go from 80% activity to 90% activity. So now let's introduce Meropenem Vaporbactam into the story. Forget about Vapor for a second. Meropenem is dosed 2Q8 as a 3-hour infusion. The susceptibility breakpoint that comes with that is 8, right? And so again, just based off of that different breakpoint, you've already gotten activity against about 50% of Meropenem resistant isolates. And then if you add to the fact that you maybe cut off one dilution with the addition of Vaporbactam, it looks like you get really good activity out of Meropenem Vaporbactam. Again, although I'm saying it doesn't really bring anything to the table, a different interpretation would be 70% of Meropenem resistant isolates are susceptible to Meropenem Vaporbactam. But know that that's really just driven by the dose of Meropenem predominantly. And if you want to go that route, you can get there with just Meropenem in that situation if you dose optimize the drug. So that brings us to right around when the pandemic took off and Imipenem Relebactam came out. And so what do we have going on here? So we have Imipenem, we know, we moderately like, and it's combined with Relebactam. And Relebactam is an Avibactam-like beta-lactamase inhibitor. It is the same class, those DBOs that we talked about before. Its inhibitory profile is similar. The one notable difference, guys, again, it's irrelevant to our talk today, but OXA48, which is a mechanism of carbapenem resistance in Enterobacterales, that's inhibited by Avibactam, but not Reli. And so again, it's a real niche for Cas-Avi. Just keep that in mind for when you're practicing and see those isolates. But again, the question is how's it fare in Imipenem resistant Pseud? Does it bring anything to the table? Well, it depends on the mechanism, right? Remember that I said that carbapenemases are rare in Pseudomonas. It's only about 1 to 2% of carbapenem resistant Pseudomonads in the US. But when they do occur, largely metallo-beta-lactamases, Vim and Imp, as we talked about earlier. Again, those are class B enzymes. Relebactam can't inhibit it, so it will not help in that situation. However, remember that chart we had at the beginning. The majority of Imipenem resistance is due to a combination of AMP-C, bumping up the MIC a little bit, combined with porin reduction. And it turns out if you take care of that AMP-C component of it, you largely restore activity in Imipenem resistant isolates. Again, look right here, your MIC 90 goes from greater than 16, 100% resistant, and your MIC 90 goes to 2, which is actually susceptible. So you actually see good activity against Imipenem resistant isolates. And this is a really important distinction, guys. It's why it's not just because I'm a pharmacist and a geek, as Keith so pleasantly said, although it's definitely part of it, but it really is an important part of the story for understanding the activity of these drugs, right? Imipenem resistance is driven by a combination of downregulation of porin and upregulation or induction of AMP-C. You give Relebactam, you take care of the AMP-C component of that, you will usually find in vitro activity. Not all the time. There can be completely shut off porin and you might not still get enough drug in, but usually you will see activity. Compare that or contrast that actually with Meropenem, where resistance is a combination of porin and efflux, and giving Vaporbactam does nothing, because AMP-C just isn't a player for Meropenem resistance. And so really it has no to limited utility, but remember what we said before, breakpoints can fool us a little bit because it'll make it look better than it is. And just to give you some data, and this is an experience that we have at Michigan as well, Imipenem Relebactam is actually extremely active against our XDR Pseudomonas. For us, it's actually more active than Zerbaxa is. And so you really do see good activity because you really do need in most isolates that combination of those two to cause Imipenem resistance. And as you can see here, very good activity even when you see resistance to 4 to 6 beta-lactams, where susceptibility to other agents is quite low in that setting. And the other benefit of Imipenem Relebactam is that even though it's limited data, there's actually some data in this space as well. So Restore Emmy was the Imipenem Relebactam RCT, where they compared Imirel versus colistin plus imipenem for the treatment of carbapenem-resistant organisms. Now, note in this study, it is an extremely small sample size, so please don't overinterpret these data. We're talking about 20 patients in one group, 10 patients in the other group. But even with that being said, so none of this is going to be statistically significant because of all of those small numbers, but boy, there's still a pretty big signal there. Look at the size of the blue lines, Imipenem Relebactam versus colistin plus imipenem, the red lines. You see this favoring of Imirel. If you look at toxicity, despite the small numbers, you're talking about a five-fold decrease in acute kidney injury. And one thing that's important and one thing that's unique with this study, guys, that I want you to be aware of is, unlike Tango 2, which was the study where they looked at Meropenem Vaporbactam, this was not a KPC study. 77% of patients in the study, their study pathogen was actually carbapenem-resistant Pseudomonas. And so again, even though the numbers are extremely small, there's at least some data that this restorative activity actually means something clinically. It actually means something in our patients, not just in the test tube, which I think is pretty darn encouraging. And so that leads us to our last friend. Friend, enemy, frenemy, I don't know. We're going to talk about it a little bit, which is Ceftriaxone. Ceftriaxone is an interesting compound. And I'm not one, even though I am a pharmacist, I'm not one that routinely puts up chemical structures just to annoy people. I do it in this situation because I think it's really important to understand and appreciate this drug. And so what I want you to see, so you can see the cephalosporin, so go to the bottom of the screen, you can see the cephalosporin core in the middle. Two side chains. One side chain is basically cefepime. This is before we even talk about the iron thing, which we're going to in a second. One side chain is basically cefepime. One side chain is basically ceftazidime. And so what this compound does, even outside of the Trojan horse stuff that we're going to talk about, is it really combines the best of cefepime and ceftaz. So even outside of the iron thing, you'd actually have a really effective cephalosporin. It's got its zwitterionic properties, which enhance passing the outer membrane. The different side chains actually enhance its ability to beta-lactamases as well. So even outside of that, out of the iron piece, you have a pretty good compound. However, look on the right side of that chemical structure at the bottom, that's our catechol moiety. And so basically what that does is, so again, to understand ceftriaxone, you have to understand iron homeostasis and infection. So basically part of our innate defenses against infection is we downregulate iron. The reason we do that is that organisms need it for their cellular processes. And so what organisms will do is they'll send out these scavenger siderophores, which will go extracellular, chelate iron, and come and bring it back in for the process. And so basically what this catechol moiety is mimicking this. And so this little catechol moiety can bind free iron, and in doing so, it'll enhance the uptake of the drug. So for ceftriaxone to get into the periplasmic space, it actually has two paths. One, it's got our normal porin, remember the OPRF that we talked about before, and because it has cefepime in it, right, it gets in there pretty decently. But then it can also take this iron transport system and get uptaken that way as well. And so what that ultimately means is that between those two pathways, you get a lot of drug in the periplasm, in the periplasmic space. Iron then dissociates, and you end up having a lot of drug right at the site of action. In addition, because of all of those chemical structure things we talked about, we have enhanced stability to beta-lactamases. So because of that, we get a lot of a very active drug right at the site of activity. So that's really encouraging. And if you look at the in vitro data that's out there, you see high levels of in vitro susceptibility against Pseudomonas, including carbapenem-resistant strains. And even though it wasn't really the focus of our talk today, guys, I do think it's important that you appreciate it. Even our kind of oddball resistance mechanisms, beta-lactamases that are infrequently seen, but compromise a lot of the novel therapies, you see relative activity of ceftriaxone. And so again, these are different beta-lactamases on the first column, but what I want you to see is that bottom part. We're talking about a cohort here that has 80% resistance to Cazavi, 96% resistance to ceftolozane tazobactam, and cefiderocol still active about 85% of the time. So again, this is often an option when there are no other options from an in vitro susceptibility standpoint. Where it gets a little sketchy with cefiderocol, though, is when we shift away from the in vitro, which again, that looked amazing, right? But when we shift away from the in vitro and we shift over to the clinical. And so let's talk about the clinical data, and I'm going to try to kind of put this in perspective to the conversation about Pseudomonas. So there's two trials to talk about. The first is the credible CR study. This was cefiderocol versus best available therapy for carbapenem-resistant gram-negative infections. This was an open-label, multi-center randomized controlled trial, and they randomized them 2-to-1 to get either cefiderocol or whatever the team wanted to give the patient if cefiderocol was not an option. It's best available therapy based off of historical treatment options. This comparative arm was largely colistin-based regimens. I think that's important because we generally think colistin-based regimens stink. And so it's important to keep that in perspective. And as you can see there, the majority of patients had pneumonia or bloodstream infection with a little bit of UTI sprinkled in there as well. And so let's look at outcomes. So first is clinical cure. The first column is just end of therapy or test to cure. And I don't really want to focus on any of these numbers. Just know that the numbers were similar. Clinical cure rates for cefiderocol, which is FDC, and best available therapy, BAT, pretty much similar across the board here. And you might say that that's a little concerning, right? Because all of the other therapies seem to do better than colistin-based regimens. But here we're seeing really similar outcomes between the two groups. But where it gets even a little bit more concerning is when you go to the mortality endpoint in this study. And so again, just to orient you, you're looking at 14-day, 28, and end of study mortality overall, and then by the different disease states. And what you'll find when you look at the data is that none of these are statistically significant, again, because the numbers are small, but you see these higher numerical mortality rates in the cefiderocol arm. And when you actually go down to the nitty gritty, it's driven by the patients we care about the most. It's the pneumonia patients, it's the bloodstream infection / sepsis patients. And so again, concerning information in that situation. But remember, this was a carbapenem resistance all-comers study. So what happens when we look at outcomes by pathogen? So again, if you look at Pseudomonas aeruginosa, clinical cure rates, the numbers get really small, but no obvious concerns are there. The concerns tend to be more with Acinitobacter baumannii. And then if you look at mortality, it really depends on how you look at it. You can see this huge, scary signal for cefiderocol. There's no doubt about that for Acinitobacter baumannii. And on the surface, it looks like it's there with Pseudomonas as well. But one thing that's interesting is when you take out the patients who were co-infected with Pseudomonas and Acinitobacter, which we already know it didn't do well in, that difference seems to go away. So again, the numbers get really small to make any sort of, definitive statements, but there's some signals that we see here that it might be driven by Acinitobacter, but really small numbers of Pseudomonas patients. And then that takes us to the Apex MP trial, which I'm thankful we have for a couple reasons. So this is a nosocomial pneumonia study, compared cefiderocol to dose-optimized meropenem. So one incredible strength of this study is that meropenem was given as 2Q8 as a 3-hour infusion. And so if you look here, this is the clinical cure. You can see that overall, no difference between the groups. And again, the numbers start to get small when you look by organism, but no obvious concerning signal for Pseudomonas, right? Those numbers are essentially identical. It's one patient different between the two groups. And so the question you might have is, clinical cure wasn't different in the credible study, but mortality was. Does that happen in Apex NP? And so if you look here, you're looking at mortality rates, cefiderocol versus meropenem, and on the surface, right, they're identical, 12% in each group. So no obvious concerns. Again, Pseudomonas looks good for cefiderocol. But what's interesting about this study is that about 25% of the isolates in the study were actually carbapenem resistant. And even though meropenem was the comparator group in the study. And so what they actually do in this study is they compare outcomes as a function of meropenem susceptibility. And in this study, because the dose of meropenem was 2 Q8 as a 3-hour infusion, they kind of considered 8 to be susceptible. And what's really interesting is this part right here. So what you'll see here is that for carbapenem susceptible isolates, mortality rate in both arms, about 10%, no difference. Again, that's an awesome finding because meropenem is a hell of a drug, right? What concerns you a little bit is that if you look at meropenem isolates greater than 8, meropenem, which theoretically is an inactive drug in that situation, mortality doubles to 20%. Again, not surprising, would expect that. But so does cefiderocol. So again, for the very isolates where you're interested in using this drug, maybe it's not performing that well. Of note, again, once my screen loads, you'll see this at the bottom. The majority of the meropenem resistant isolates were Acinitobacter, again in this study, about 70%, and that's what drives this. And so the question that we don't know is, does this hold true for, again, Pseudomonas, for Enterobacterales? But again, you have all of these kind of warning signals that are there. And so to summarize cefiderocol, I think I would say, and I have one more slide left, so we're almost there. The in vitro activity is amazing, even including against isolates where nothing else is an option. But there are extremely disappointing clinical trial results against the very pathogens and the very patient populations we need it for. I think it's fair to say this might be an Acinitobacter issue, but we don't really know. And so caution does need to be applied in this situation. And so taking that all into consideration, this is kind of the summary last slide. How would I think of these drugs for Pseudomonas infections? I think first and foremost, when it's available, ceftolozane tazobactam should continue when it's active to be your go-to agent. You do need to know local susceptibilities because there are resistance pockets, but remember, we have active parent drug, we have great PK/PD, we actually have published clinical data showing it to be efficacious in these patients. But right now we don't have CT, right? So what comes next? I'm a believer that Imipenem relebactam is our next shot. The reason I say this are threefold. One, it's usually the most active of other agents. It's got very good in vitro activity, and that makes sense mechanistically. Even though small studies, you have some positive clinical data. And then unlike Vaporbactam, I think they've actually done a robust PK/PD preclinical work showing that the exposures of relebactam are pretty good. And so I feel more comfortable in that drug. 3 and 4, I think, are somewhat interchangeable. I actually put cefiderocol third because it does have extremely potent in vitro activity. I think it's fair to push back on me and say, what about those clinical concerns? I do believe that it seems to be an Acinitobacter problem, and I think the preclinical data actually suggests it might be an Acinitobacter problem as well. But from an in vitro activity standpoint, and from a not an obvious signal in Pseudomonas, I think I put it third. I put Cazavi fourth for all the reasons that we talked about. Again, PK/PD concerns and lacking clinical data. And then finally, Meropenem Vaporbactam should be at the bottom, because remember, Vaporbactam isn't really adding anything. And if you want to use it, just use high dose extended infusion Meropenem. So I know we're right up against it time-wise. I'm happy to stay on as long as you guys want, if there are any questions or anything else you want to discuss. Thank you very much for having me.
Jason, as usual, that was awesome. Thank you so much. I know if people need to drop off, that's fine, but I think we do have time for a couple questions. So I'll just kick things off. Is there anything in the pipeline that's not currently available that you're excited about for Pseudomonas or non-fermenters?
So non-fermenters, yes. Pseudomonas, not necessarily. I think the big thing in the pipeline that is on my radar is, I guess there's 2 things. One is the entasis compound. It's sulbactam plus durlobactam. So durlobactam inhibits the class D enzymes that are problematic in Acinitobacter. And sulbactam, it's restoring the activity in that situation. And I don't know if you guys saw it or not, but they released their top line results. And unlike cefiderocol, which the top line results are kind of ugly against Acinitobacter, it's the flip. for the entasis compound for Sulbactam, Durlobactam, that it seems to, even though it's a small study, both clinical cure and mortality seems to be favoring the novel agent. So that's really exciting because I think Acinitobacter is a huge hole and a huge problem that we have, and it's really encouraging. Again, we need to see the actual data, but it's great to have good news in the Acinitobacter space. And then two, I think the other thing, Keith, that's exciting and scary all at the same time is having an oral carbapenem coming up soon, right? This is going to be a big deal for the management of ESBL infections. It's going to be a hugely important role for stewardship to make sure that it's done right. But I mean, everybody on this call knows how problematic it is to treat even a simple ESBL infection in the outpatient setting. So I'm really excited about that as well.
But Jason, tebipenem is not a pseudomonal drug, correct?
It's not a
really more of
pseudomonal
an
drug.
ESBL drug.
That is
just
correct.
For the fellows, I wanted to make sure. Anyone else have any questions for Jason? And please don't be shy.
Not everybody all at once.
Nav, I know that you have a newborn at home, but I know that I see you on here. From ID PharmD to ID PharmD, any questions for Jason?
Not too many. Jason, that was a really good talk. Thanks for taking time to visit us here in New Jersey.
The travel was hell, but it's good to see you now.
Yeah, I mean, I guess the only thing that I was wondering is, you know, we've looked at cefdiericol in terms of their breakpoints, and I agree with everything that you said, but one thing that always sort of troubled me is with the PK/PD, the level of exposure that you need is pretty maximal, and if you sort of get under that, then you're starting to run into trouble in terms of, you know, that PK/PD index. So any sort of insight, you know, in your experience or your research of, you know, sort of why that is from a drug compound standpoint, without getting too much into the
without getting into the nerd, not going too far into the nerd world.
Yeah.
Yeah, I think that you're exactly right, Nav, and I think that it's even more of unknowns in the Acinitobacter space, to be honest with you, which is one of the reasons I think that it might be real that it's not actually good against Acinitobacter, and I'm very wary about using it. So for those that don't know, which is probably everybody that's not Nav on this and doesn't pay attention to this nerdo stuff, is that in the preclinical work for this drug, usually with a beta-lactam, you have a pretty clear time above the MIC target. But for cefdiericol, it's all over the board. It's anywhere from like 20% time above the MIC to 100% time above the MIC. And again, I think a lot of that actually reflects that we don't totally understand the PK/PD as it relates to the iron piece of the story. But so what I do, Nav, in that situation is actually take the most conservative measure. So I kind of think the minimum for cefdiericol should be time above the MIC of 100%. I think that's the appropriate way to do it, to be conservative. And if you do that, basically the breakpoint, I actually agree with the systemic breakpoint of 4, because you actually do get pretty good systemic exposures with the drug. I think where it gets hairy, though, is when you're talking about a pneumonia and you take penetration in. And if you kind of do the nerd piece of that story as well, I think the breakpoint should actually be a dilution lower. But again, cefdiericol is definitely not a first-line drug for me. And so usually when we get there, Nav, as you know, we don't have a whole lot of choices at that point. And it's why we'll often do it in combination with other stuff.
No, thanks for that. Appreciate it, Jason. Once again, it was a really good talk. Thanks for coming out.
Have any other comments or questions for Jason? Okay, Jason, thank you so much. I always learn something from you, so I learned today was no different. Everyone have a great day, and I'll see you all soon. Everyone take care. And thanks again, Jason. Bye-bye.
Thanks, guys, and thanks for the breakpoint shout out.
Thank you.
Later, guys.
I'm a huge fan.